Okay, good morning and welcome to Endocrinology Grand Round. I will present two cases. First one just by me, and second will be sharing with oncology, surgery, and anesthesia departments. So first case, about 57-year-old female patient previously known to have diabetes on PO medication and newly diagnosed breast cancer. So actually we saw her during a social visit while she was taking chemotherapy for her cancer. So first, looking at the patient, certain facial disfigurements were clearly noted. Her nasal cartilage appeared enlarged, mandibular bone appeared widened and protruding, and brow bone also looks also protruding. So we asked her to show us an old picture to her. So this is old one, 10 years ago. So when we asked her about feet size, she said, yes, my feet increased in size from 40 to 44, and my ring no longer fits to my finger. So we suspect here a case of acromegaly. So next step, we did all pituitary hormonal workup and showed a significant elevated in IGF-1. So next we did MRI pituitary with gadolinium, and showed 1.4 centimeter pituitary adenoma. So our findings is enlargement feet and hands, significant elevated in IGF-1, and presence of pituitary adenoma all suggest our diagnosis of acromegaly, which is our topic today. So this is my outline. So I will start by definition of acromegaly, brief reminder physiology about growth hormone secretion, what is the epidemiology, pathophysiology of the disease, screening, and follow-up. So these are my sources from Endocrine Society of Clinical Endocrinology and the updated guideline in 2020. So acromegaly, by definition, is a chronic disorder caused by growth hormone hypersecretion. So a pituitary secretion of growth hormone, usually regulated by two hypothalamic hormone, growth hormone releasing hormone, stimulate growth hormone secretion, and somatostatin inhibits growth hormone secretion. So growth hormone secreted from the anterior pituitary in a pulsatile form and has a short half-life, and most effect of growth hormone are mediated by another hormone, IGF-1, usually secreted mainly from liver and other organs, and IGF-1 feedback to the anterior pituitary and suppresses growth hormone secretion. So concerning etiology of the acromegaly, so most cases, more than 95% of cases is growth hormone secreting pituitary adenoma, and around 5% is GnRH secretion, so it's a tumor. Could be at the level of the hypothalamus or a neuroendocrine tumor, and very rare cases could be ectopic secretion of growth hormone from either abdominal or hematopoietic tumors. And also very rare cases could be secondary to several genetic mutation contributing to this benign entity, or could be a part of MEN1, or also a germline mutation described as familiar acromegaly. So concerning epidemiology, so prevalence of acromegaly is about 36 to 69% cases per million, and incidence 3 to 4 cases per million per year. And men are significantly younger than women at the time of the diagnosis. However, women may show both increased in incidence and mortality risk. So when we have hypersecretion or of excess in secretion of growth hormone, so leading to multiple system disease characterized by somatic overgrowth, multiple comorbidities, premature mortalities, and physical disfigurement. So clinical manifestation of patient with acromegaly, so may have enlargement feet, enlargement hand, presence of hepatomegaly, splenomegaly, and also could be symptoms secondary to mass effect of the adenoma. So patients can complain from headache, visual defect, and also disfigurement of bone face, especially of the mandible, and nose cartilage enlargement. So what about diagnosis? So the gold standard to diagnose acromegaly is measured IGF-1. Why IGF-1? Because IGF-1 has a half-life about 15 hours and relatively more stable than growth hormone, because growth hormone is a pulsatile secretion and has a short half-life about 10 to 20 minutes. So IGF-1 is generally more helpful than growth hormone in the diagnosis of growth hormone abnormalities. And also all IGF-1 levels must be assessed in a relation to age-appropriate normal value, and we recommend against using random growth hormone level due to pulsatile form and short half-life. And sometimes we use growth hormone, but after oral glucose tolerance test and IGF-1 to assess the acromegaly disease activity and at the time of the diagnosis and on follow-up. So we have many situations can cause mildly elevated or falsely positive or negative or to IGF-1 value should take into consideration, like hepatic renal failure, hypothyroidism, malnutrition, pregnancy, and later stage of adolescence. So when we have mild elevated in IGF-1 or equivocal value, but still we suspect clinically case of acromegaly, so we go for confirmatory test, so confirmation by oral glucose tolerance test. We give 75 grams oral glucose and measure growth hormone at T0 and 2 hours later. So in normal physiology, growth hormone should decrease less than 1 microgram per liter after hyperglycemia after loading glucose, while lack of this suppression usually seen in acromegaly. So we confirm the diagnosis. And after after biochemical diagnosis of acromegaly, we recommend performing an imaging study to visualize tumor. So the gold standard is our MRI pituitary to characterize tumor size and location and invasiveness. And up to 77% of cases are macroadenoma at the time of the diagnosis. And also we suggest performing a visual field testing when the tumor is found to border the optic chiasm on the imaging study. So why should we diagnose and treat acromegaly? Because acromegaly is associated with multiple medical comorbidities, like mainly like diabetes is the main metabolic consequence of acromegaly, because the growth hormone hypersecretion leads to lipolysis, decrease glucose uptake in the peripheral tissue, and also enhance gluconeogenesis. And the percentage of patients newly diagnosed with acromegaly is about, with the diabetes, is around 15 to 38%. And also for colorectal polyps, carpal tunnel syndrome, hypertension, sleep apnea, and cancer. And although these comorbidities are very common, however, there is no compelling evidence supporting the value of biochemical screening of large patients population with this common comorbidities. So screening for comorbidities, first we suggest screening for colon neoplasia or colon polyp with colonoscopy at the time of the diagnosis, and also we suggest do ultrasound if there is any palpable nodules on physical exam, and also screening for diabetes and insulin resistance by A1C, fasted blood sugar, or random glucose level. And also screening for any valvular heart disease or acromegaly, cardiomegaly via echocardio, and also screening for sleep apnea by polysomnography, also for breast and prostate cancer. Excess mortality usually reported in early studies was primarily due to cardiovascular disease, and also cancer reported as the leading cause of death in patients with acromegaly. However, the rate of thyroid malignancy is not greater among acromegaly patients, among patients without acromegaly. And after screening patients with colonoscopy at the diagnosis, we should perform similar to the general population as previous recommendation. And this study done, and one study done in Taiwan, including 1,195 patients diagnosed with acromegaly, following years from 1997 to 2013, showed the incidence rate of cancer is about 10.6 per 1,000 per year. And also this is a cohort and meta-analysis study evaluating cancer incidence in acromegaly. So most common cancer in acromegaly is colorectal cancer, and also breast prostate cancer. Overall mortality was elevated in patients with acromegaly. So mortality can be related to acromegaly, not to the specific cancer mortality. So concerning treatment of acromegaly, so first-line treatment is a transsphenoidal surgical resection of the adenoma, and however, most of macroadenoma are cured after surgery, and 40 to 60% of patients with macroadenoma are not controlled by surgery. So here we go for adjuvant therapy to complete treatment. And the rate of total tumor resection was significantly higher in men than women, and however, women have a lower surgical remission rate, and patient's age is likely not a predictor of a surgical outcome. So following the surgery, we measure IGF-1 usually 6 weeks later, and in some patients maybe IGF-1 still mildly elevated up to 6 months after OR. And then we measure growth hormone and IGF-1 usually after 6 to 12 months, so usually screening yearly for if there is a risk, because there is a risk of recurrence of the disease. So sometimes patients need to medical therapy because recurrence of the disease, persistence of the disease, or patients not candidate for to operation. So we have there is 3 drugs classes for the treatment of acromegaly. So first, somatostatin analog, because most growth hormone secreting tumors have somatostatin receptors, and this class of medications act on these receptors, response to exogenous somatostatin, and decrease the secretion, and also significant reduction in tumor, so cause shrinking of the tumor. And the second line treatment is a growth hormone receptors antagonist, so binding on the receptors and block most effect of IGF-1, so no IGF-1, and so decreased a clinical manifestation of acromegaly, and dopamine agonist. So for somatostatin analog, we have either an injectable form or PO form. So injectable form like lanreotide, pasireotide, and octreotide. And in a primary study of for lanreotide 120 milligram dose for patient treated first with surgical resection for macroadenoma, so more than 20% of tumor reduction was achieved after 12 weeks of surgery, after 12 weeks post-surgery and treatment with lanreotide, and around 63% tumor reduction achieved after 48 weeks post-treatment. So also we have a phase 3 PIORA study, which randomized around 198 acromegaly patients. So this group of patients have uncontrolled on octreotide. So we switch him to the same family but another drug, pasireotide. So conclusion or result found that 15% and 20% of patients treated with pasireotide by 40 milligram and 60 milligram achieve biochemical control. So biochemical control means decrease in IGF-1 and the growth hormone after 24 weeks post-treatment. And recently FDA approved in 2020 for PO medications of octreotide. So we used in patients with respond and tolerate injectable form. And this is the doses 40, and we can reach up to 60 milligram per day to be optimal for most patients. And second medical line treatment is a growth hormone receptors antagonist, pegvisomat. So it's a human growth hormone bindings to the growth hormone receptors and block, as we said, production of IGF-1, so leading to improvement in metabolic and clinical effect of acromegaly. However, this type of treatment or this family does not appear to effect on the tumor size or don't shrinking the tumor or decrease in tumor size. And also we can give a combination between somatostatin analog and growth hormone receptors antagonist. So this combination showed a significant biochemical control of the disease and reach up to 70%. And also it's a cost-effective and efficacious for many patients who have persistence or recurrent disease. Concerning radiation therapy, so radiation therapy is our third-line treatment in acromegaly, so used sometimes in patients also with recurrence or disease or huge adenoma at the time of the diagnosis after we did resection. After radiation therapy, decline in growth hormone may take many years, and total effect may seen after 15 years. And most patients, many patients after treatment by radiation therapy can develop hypopituitarism, panhypopituitarism, visual defect, and secondary tumors. So finally, take-home message. So acromegaly is a chronic disease, gradual soft tissue enlargement. Best test for screening is IGF-1. And any patients with acromegaly, we screening for cancer is recommended, especially for colorectal cancer, breast, and prostate. First-line treatment is a surgical resection, transsphenoidal surgery, and also we have many medical treatments are also available as adjuvant therapy post-operation. Thank you.